Well, it's a great presentation for all our panelists. I want to just hang on a couple seconds with Dr. Purnell. So the question would be, or one of the questions would be, what would people value more than smoking if you're going to incentivize them to make these changes? What ideas do you have around that?
We're very interested in particularly households with children, so savings towards educational goals. But the Center for Social Development has been doing this asset building work for 20 plus years now. And the kinds of things people are saving for are down payments on homes, starting a small business, saving for education, saving for retirement. So we think those superordinate goals are out there. And we know from the literature that a lot of smokers are motivated to quit because of their children. So I think the intervention would probably be most promising in those households that do have children.
Okay. Well, a lot of that's going to be culturally based, and I'd asked our other panelists to talk about how they've been so successful building the cultural changes around their interventions.
Can you hear me? I guess I'll go back to my impulsive comment from earlier. What's really where I said, the problem within medical education is that the informal curriculum is to blame the patient. So at CASA, what's really been important to us is making sure that we develop programs that are responsive. Yes, there are things from a health and wellness point of view that we think matter. A lot of my background is in cancer screening, and that's why we ask a lot of those questions through our surveys. But with the key informant interviews, we really want to make sure we were listening carefully to what's of concern, what all sorts of assets that people have, what strengths and assets our community was bringing to us that really could blossom on its own and we needed to be attentive to. So it's being in that listening and responsive mode that I think is at the heart of how we work to make our program culturally respectful and appropriate. Lots of other things like having nice space and Spanish-speaking staff, but those are, I think, kind of the big foundations of how we do our work.
Okay. And in terms of networking with the culture of black males, Ms. Dean, how did you incentivize them to stay in the program you initiated?
Of course, at first, the incentive played a role, and our data showed that even after they got in the program, they would be in the program again if there wasn't an incentive or stipend that was given. I think having the men there, having them involved in the program, and for many of our programs, we have the community members at the table from the very beginning of the program. It's so important to have people at the planning stages of a program. Even a federal grant or any type of program that you plan to implement in the community, having them at the table at the planning stages is so important. Many of the men, as we heard during my presentation, they need someone just to listen. I have been so engaged and so passionate about this program, and I feel that many of the programs target women and children often don't even see the importance of male involvement. And I have been crusading for this for many years across the country, and even when I was in Washington on an international position, that has to be a priority. We should have an office of men's health, as well as we have several offices of women's health, but there is no office for men's health. There is something wrong with that. So these are the things, and I basically am on the front line, on the ground level, listening at these men tell us their stories. There is a lot of hopelessness. Men feel invisible. There should be policies that we started many years ago with our program, not this particular program, to where we had to get providers to actually be associated with letting the men come in. When the women would go in with the children, the men would tell us that they would sit in the car because they felt invisible. There was no eye contact with the men involved when they would go in. And so we created father-friendly policies associated with Neil Tiff out of Washington, D.C. And Neil came down, and we had a lot of interactions and provider workshops and trainings. And we found that many of the women that are associated with the social service networks that provide services for many of the men are by women, and many of these women have issues themselves. And many of the men said they felt that they weren't appreciated, they were stereotyped when they would go in for many of these services. So there's a lot of things that go on behind the scenes, and that when the men sit down and really have someone to listen to them, then you will get the true answers. And we find that many of our risk assessments, many of these men are very truthful with their answers.
Excellent. You'd mentioned, Dr. Matthews, some issues about ethical concerns in some of your research. Would you expand upon that?
One of the things that we really have to be mindful about is the particular vulnerabilities within a population where many people don't have legal status. So all the ways in which there's discrimination, there's actual danger from perhaps coming into contact with law enforcement. Because we have navigators who go with patients, we have documented examples where people got harassed within our healthcare systems in St. Louis and told, if you come back to this hospital again, we're going to call immigration. So some really horrendous stuff. And so part of how that influenced our data collection, and especially on the qualitative side, we really found that the one-on-one conversations were probably the safest in terms of trust building and people being able to speak freely. And also because it's such a new population in this region and there's so much we don't know, that allowed us to go very deep into some areas that maybe in a group people might feel less comfortable talking about. It's also come up in some of the information we've collected at intake. So I often speak in audiences like this that one of the huge interventions we've had is around screening for some of the communicable diseases that were mentioned earlier as being a big problem in this state. So we have a very high rate of people opting in for screening for STDs, but that's something that we keep under this umbrella of discretion. We wrap it into our clinic. Every clinic visit, it's offered to people. But it's something where we allow people to come in and do that discreetly, not have a lot of attention called to that. So there are lots of ways in which we're mindful of protecting. It's kind of beyond human subjects protection and beyond HIPAA. I mean, those things matter, but there's this whole other layer of responsibility to protect people and keep them safe and make it safe space that we work with all the time.
I know with, not here in Missouri, but I have colleagues that are emergency physicians in Phoenix. And one of the side stories I've been told is how just in terms of seeking emergency care, if there's law enforcement parked outside the emergency room, the Hispanic number of patients that come into the emergency room who legitimately need care, they don't get it because of these issues of potentially being deported and so forth. So a lot of ethical concerns around that as well. So you've all had these wonderful innovations that have worked. Can you share with us, because I'm sure we'll want to try to duplicate some of those, what hasn't? What were some of the challenges you had that didn't work in terms of being successfully able to implement your interventions?
I think just more time. Having more time. Many of these men, our programs last 3 to 4 to 6 weeks, but it really takes about a year to put a man in a program and follow him and do the appropriate case management steps. Look at if he needs the job training, he needs the skills training, he needs all the opportunities to get back into the community. It just takes more time. And we are limited with specific programs and funding, but the more time, that will give the man more time not only to get back with his family, but to bond with his children, for us to work with him, to feel that at least someone is listening, and there just needs to be a period to where they can come in and really go through the psychological challenges that they have, specifically if they've been incarcerated. So we have all of those challenges and barriers that we have to face with these men in a short period of time. And the case management aspect is also an important part of the program.
I'm going to touch on 2 things that haven't worked. We don't do direct pediatrics. Children are more likely to be Medicaid eligible, and in the FQHCs in general reach a large part of the population in St. Louis, not everybody. But we did want, because families wanted us to provide services for children, we have tried a couple different things, and one thing that works quite well is dental. So we work with Children's Hospital, Healthy Kids Express, to provide dental services for children, and that's a very sought-after program. We did try through both Children's and with one of the FQHCs to do screening visits, where kids would just come in and get height, weight, probably lead check, something else. And we tried this during the academic year, and it just flopped. And as we put it together, it's realizing for the parent to take time off from work, to line up a ride, because 90% of our folks get to us by car, but not necessarily their car, to pull a child from school, that there were so many things to line up. And for a child who didn't have an active problem, nothing materialized. On the adult side, and we do this now through our intake, what we just used to ask as background informational questions now filters into how we provide care. We do all these kind of screening assessments, where you are with cancer screening, STD screening, as part of the intake process, and then we just do it while folks are there. So we wrap in a lot of preventive and wellness services. We don't make people come back for just a separate wellness assessment.
Okay, thank you. Let's open the questions to our audience now. I'm sure they have a lot of questions about these innovations that have been started. And we have people with microphones out in the audience.
Hello, I'm Idalia McNulty. I work with the Department of Health and Minorities Office. I'm new. I want to commend the three of you, for the wonderful job that you're doing. I am a professional that had worked in the health for 10 years. One day I ended up without a job, and I didn't have insurance. And I always preach to everybody, oh, go to the federally qualified centers and blah, blah, blah. I went and called. They had an appointment for July when I was in May. So I called Casa de Salud, and I went, and I had the most wonderful experience. As a person that worked in the health areas in Missouri, I noticed how wonderful it was, professional, people speaking my language. I felt at home, and I really commend you guys for that job. I also work teaching teenagers, and one day they asked me to teach the teenagers the male, the teenagers, and they were telling me, and I never knew, even my own attitudes. I used to think, oh, these guys get these girls pregnant, they disappear, and things like that. And I know that they want to be part of the child's hope. They want to be part of their lives, but we sometimes as a society don't let them, and they don't have anywhere to go. So I also commend you for all that work that you're doing with the men. So thank you.
Other questions? We're here.
My name is Chris Haynes, and I work for Phoenix Program.
A little louder.
I work for Phoenix Programs. Is it not on?
There you go.
Can you hear me now? Okay. I was wondering, is there some statistics that show the Black Hispanic community of homeless? Because I haven't heard that really talked about. Because they are the ones that I work with, and you really can't hardly find services for them. And as far as they're really afraid to go get the help that they probably deserve based on alcoholism or drugs or whatever that goes along with that. Is there some statistic that talks about that?
No.
I apologize for not having statistics. I did early on talk with folks at St. Patrick's Center in St. Louis, and just interestingly, they could only recall 2 Latino men kind of coming through their services. We do partner with some of the shelters in town, so especially women and children who are in unsafe situations, who are in those shelters, and so residing there for issues of domestic violence. What we haven't really explored is the complexity of people's living situations. So we haven't really asked so much about this directly, but stories filter back to us about many, many people living in small spaces. So there's certainly a precariousness in terms of the space in which people live, and probably worth understanding better than we do now.
I would also say that some of the ethical concerns come in with this as well in terms of data collection in the homeless population in St. Louis in particular. There's an effort to try and eradicate homelessness within the next several years, but people are reticent to give their information because they have privacy concerns. Just because they're homeless doesn't mean that they want to be tracked or want people to know where they are, so that puts another layer of complexity over the whole data collection question.
And also the local health department and the Office of Social Services have the data, the local data for Colombia. Every year they get together with other faith-based organizations and they have the data and the numbers. So you can get it there.
Yeah, that is an important segment, and it fits with the other invisible people we've talked about here. Clearly, homeless is one of those. And I think just in terms of even taking medical history, you know, when I went to medical school, and it's still the same thing now, you look at the chief complaint, the history of present illness, and then you look at their social history and their family history. And typically, social history is just asking them about whether they smoke or drink. And we really don't get down to some of the important cultural aspects, socioeconomic factors. Are you employed? I admonish the residents all the time. Someone will come in with a urinary tract infection and they'll give them a prescription for Levaquin, which costs, you know, $50. And it's like, well, you've wasted the patient's time because they're not going to spend that money. We need to give them a less expensive antibiotic, but we don't even take the time to look at those other social aspects of their care, which are important. Other questions? Yes, ma'am.
Hi, my question is for Ms. Dean. Since you said a lot of the men enrolled in your program had been incarcerated, do you track recidivism rates?
Yes, we do. We find that many of the men that have been incarcerated, there are a lot of barriers. We work with them one-on-one. We find that many of the men, the biggest problem is the community itself. A lot of times they have to be reintroduced into the community, trying to get them to feel comfortable going to look for a job. If they have a felon, they automatically can't apply for some jobs. We work with the men, or some of the men will say, well, you know, I just might as well lie because that's the only way I'm going to get a job. And so we tell them no. But we do work with the men and try to track them. And one of the things that I want to go back and just address the homelessness situation. Many of the men are technically homeless, but they live on grandmother's couch or their girlfriend's couch or a neighbor's couch from home to home. And keeping up with them is also a challenge after they exit the program because they're in town, but they may have changed girlfriends or they're in another area. One of the things that we're trying to do is to make sure that they have enough education and training so that they will improve their skill levels. That's why more time is needed, because the skill level is something that they need to get certification in, whether it's electrician or welding or bricklayer. Or we actually introduced the concept through our Chamber of Commerce that they could actually get what they call some type of a license. It's not a hobo license, but it's some type of a license that you can get and just go in handyman's license. You can go in and get a handyman's license. They did not know that for $25, you know, if you have basic skills. So there are a lot of things that we work with, and we also work with the Department of Corrections. They come in and speak at our graduation and let the men know there are various programs available that they are not aware of, even though they have been incarcerated.
Thank you. Other questions?
Dr. Pornell, I'm fascinated by your research. I really are. And I'm wondering if we were able to pilot this in real life and we were able to create an incentive in which, for example, smoke cessation programs will be implemented, what would be the odds that in crisis, an economic crisis like the ones we have right now, that program would actually work? Because smoke goes very attached to stress, and it's a way to release anxiety. So how you work that out? Because of course the population that needs the most health is the one that is the most stressed, and is the one that has a lot of the everyday life situations. They are just not always fair, and they're recurrent, and they're cycles, and they're not moving. It's income, it's just life for them. So how would that work out?
It's a great question, and I almost answered the question about what hasn't worked with what I'm afraid will not work in terms of this intervention, and that's part of it. And in psychology, we call it self-regulation, the fact that you're asking somebody to control their behavior in a domain like savings and smoking at the same time. I think what we're banking on is that superordinate goal that we're talking about. So even people who are in dire circumstances are highly motivated by their children, or highly motivated to provide a home for their family, or highly motivated to get an education. We're hoping that that becomes the motivator, but also giving people the tools for different ways of coping, which many evidence-based smoking cessation programs are going to do. They're going to give people alternative ways of coping with that stress. And we don't want to, the incentive is not the intervention. The smoking cessation is the intervention. We're laying the incentive on top of what we hope to be evidence-based smoking cessation, which would deal with that sort of stress management question.
Because for me, one of the fascinating components is the healthy coping mechanisms that you mentioned. They are so true for any chronic disease. So if you're able to teach people how to actually, here it is. If you're able to teach people how to actually manage stress through healthy coping mechanisms, either walking, either no eating, either not get really anxious, aggression, you not only manage the everyday life diseases, but you will start manage chronic diseases that in the long term may have an impact.
Well, and one of the motivations for this intervention strategy is really a frustration on my part with preaching to low-income populations about health behaviors. You really ought to stop smoking. You really ought to go get your mammogram done. When they're worried about how can I keep my lights on? How am I going to pay the electric bill? When I was working in Rochester with the African American Health Coalition, there was a gentleman in the community who said, "You want to lower my blood pressure, help me pay my heating bill." So to the extent that we can deal with people's real socioeconomic issues, those kitchen table issues, I think we have to do that in addition to providing the evidence-based health interventions. That's the thinking, at least.
Thank you.
So how do
Can I
we
make
get
a
to that?
comment?
Well, let me just finish this. So how do we get to that? Because it's been brought up many times about these social economic issues and being able to find that valued leverage point to make people change their behavior. So, how do we get there?
I think part of how we get there is, quite frankly, from a political standpoint, the nation and policymakers are not particularly motivated by health disparities or the moral case for health disparities. We have to make the economic case for dealing with health disparities. This is costing us money. People in this room care about the moral case, but the wider world is going to need to know that those lives that you're abandoning cost you money. And it costs money to leave entire segments of the city of St. Louis abandoned. We need to make the case that everyone has the potential to be a contributing member of society, and their health is a part of how they contribute to that society. And make it in concrete terms. Show them these are the dollars that will be saved, or this is the investment that's required.
Well, some of that, I mean, clearly is known, because we know when people go to the emergency room or they're hospitalized for chronic diseases, it could have been taken care of more efficiently through preventive mechanisms. And then all of our insurance rates go up, so we all pay for it on the back end. So does it need to be more grassroots? Do we just need to educate our politicians better? All of the above?
Need to go.
Okay. Another question?
I have a comment. I have a comment about the cigarette smoking and the cessation. I think psychologically speaking, all of us that smoke or smoked, and particularly lower income people and people with mental illness, reward ourselves. We see cigarette smoking as a reward to ourselves. And so when you are struggling financially, to think about taking away what we have perceived as a reward is almost like another loss or punishment. So I think what worked, for me and what I've seen work for other people is we have to change how we perceive cigarettes from a positive, which is a reward, to a negative, and we have to start giving our, helping them to understand and say to themselves, what the negative consequences of it are too.
I totally agree with that, and I think a couple of things. So behavioral economics, which I'm very interested in, talks about delayed discounting. So we have these very sort of far-sighted thoughts about, well, if you ask me a week from today, will I eat a cheeseburger? I'll tell you no. But if you put a cheeseburger in front of me, the likelihood is I'm going to eat that cheeseburger. The hope is that that financial incentive acts as its own reward, so that it replaces the reward of smoking the cigarette. That's part of the logic of providing the incentive, is that there's actual monetary incentive involved in you quitting smoking. It's not a perfect intervention, but it's at least attempting to replace that reward that you got from smoking with an actual tangible financial reward. But I would note that this isn't going to be for every smoker. It's going to be for people who are prepared to quit smoking. And we know that smoking makes poor households poorer. So the financial burden is actually because of the cigarette smoking, at least in part.
Follow-up question over here?
Yeah, I would just like to comment on what has been said, and what I find in my dealings is that people are stressed out and they smoke a cigarette because of the fix that nicotine gives them to cope with the stress. And some people smoke cigarettes because it gives them a greater high when they drink liquor. There are so many different factors of why people smoke, but what has been proven is that if that cigarette tax had passed in Missouri and the rate on that tax was high and you can't afford to smoke, that makes a difference, because we were just at the African Arts Festival, Janice Evans sitting over there, and Valerie, and there were a group of people that were smoking that were from out of town. And they said, we were very happy when we got here and saw the cost of these cigarettes. In fact, the guy said, I'm going to get me a bunch of cigarettes and take them back with me, because I can't afford to buy all these cigarettes when I'm up on the East Coast. And as far as that cheeseburger and other foods and all the foods that we try to prevent people from eating, if you can go to the corner and get a cheeseburger for 99 cents and you only have $5 and you're looking at trying to eat, and a Chinaman, you can go get you a half order of fried rice for a cheap amount, and you can go get you some ramen noodles that are high as I don't know what in sodium. You can talk to people all you want. I got to live, like you were saying, people got to live, and it's all about that cost. So I find it's more effective to show people that if you go to Aldi's on the corner, Aldi's actually offers some products that are real good products that are all natural at a good price. You know, so I just think we have to think outside the box. And the first thing, though, that I think is that we have to start going in the communities, meeting people, touching people. And I don't mean just when you have a study that you want to do, okay? That means that you need to just go and meet the community and be out in the community. And it may mean when you get off work, you need to volunteer because you have these professional skills, okay? And when these kids look up to you and you're a black man and you had a PhD, if they would just see you more, because unfortunately, a lot of people in minority communities, when they start making that money, they move out the community, okay? So if all the people with that money move out the community with the PhDs, with the MDs, with the law degrees, and all you see are people that don't have them in your community, then you'll think that's all you know, is what you see. So I still live in the community that I grew up in, even though it's one of the worst communities when I was growing up, and I took the education that I received, and I started educating my community, showing my community, but the big thing is they get to see me. And I let them know I never leave my community, okay? I love my community. I don't care what people say about it. But it's just interesting as I listen to the conversations here, and I just wonder how much time people spend in those communities that you servicing when you make those 100,000 plus salaries and things of that nature.
Excellent comment about being visible as opposed to being invisible. So thank you so much. Yes, ma'am.
I'll just make a very quick comment. I know we're running out of time, but one of the concepts or thoughts that I often have around health disparities and health equity is really thinking about or looking at how we're assigning value to our populations. But I guess what I really want to know from the panel, as you are working with your populations, those individuals that are assisting, if they really don't have the same thought process as yourself, that being that you want to help the population to the best of your ability, that someone really just sees their opportunity as a job, how do you get these individuals to really understand the importance of helping the patient populations or the populations in which you're serving to understand that they are of equal value? That's one of the biggest issues that I'm finding, that if I'm at the table with individuals and we really are working on solutions, everybody say that we feel the same and yes, we want to try to make an impact. But then when I find when everybody goes back into their own individual areas, that when I try to watch them do their work or if I'm observing, I don't see them really to be as passionate as they say as they are when they're around the table. So I just again have that question is how are we really assigning value to the populations? And why am I so interested in spending enough time with one population and giving them all I have, but I don't do that for the next population that's experiencing the same disparities? So I just want to hear from the panel how you guys have been able to overcome that.
I don't know if this is really going to answer your question straight on. Sorry. I once told our executive director right after he was hired that he was almost as important as a medical assistant. So we pay a lot of attention to the people we hire for front desk and for supporting our patients through the visit. And I think Ryan again talked about this with cultural competence, or at least alluded to it. It's the folks in the trenches of providing the care who really define the quality of the experience. So we intentionally pick people. We've been commended. I'm going to call them out because they gave us the compliment. Leadership from People's Health Center walked into our CASA one day. They come by a lot, and they're like, oh my gosh, your receptionists both stood up to greet me and they smiled. So we know that it's really valuing those employees since they're the ones who then help our patients feel welcome. And then frankly, we don't pay a ton, but we pay more than other clinics in the market do because we know that that part of the experience is so important.
Okay, well listen, I want to thank our panel for giving us a lot of innovative practices that we should consider taking back into our own neighborhoods and be successful with. Please help me thank them.
Thank you, and we're going to invite Ryan Barker and Shannon Canfield back on up to sort of wrap it up and talk about what happens after this. So you took a day to be here, and we're so grateful for that. What happens now?
Thank you. First of all, thank you again to the panel, Michael and Jason and Catherine and Cynthia. That was a great conversation. And that was a perfect example of what we were hoping to accomplish today. It's wonderful and great that we can produce this data and distribute it and have it available, and what does it tell us, and ask those questions. But to have these type of conversations feels to me like, what's the next step? Okay, let's do something with it. Like, I love data, I love looking at it, I'm a big geek like that, but I really am passionate about what's the action step, and I want to make sure that is always there. So I thank you for coming, because without the audience here to talk and engage and interact and to really share your stories and the work that you're doing, that's the importance of today and the importance of the work we're doing. So I would encourage you to continue that engagement. And one of those ways is there is a reason that the Missouri Foundation for Health supports the Missouri Health Equity Collaborative, and it is a place for us to engage each other, share experiences, lessons learned, good and bad, what worked, what didn't. And so I would encourage you to engage, continue to engage in that type of conversation. I would be remiss if I did not point out that Dr. Robert Hughes, our president and CEO, did come to the conference, and if I could ask Bob to wave. He is here just to introduce him. So I thank him. I think you were up in Kirksville, is that right? And swung by, which is very exciting. I'm glad he was able to join us. Michelle is waving the purple form at me. None of us love to fill out the evaluations, but we really do appreciate feedback. What did you like about today? What didn't you like? Let us know what worked, what didn't, so that we are always open to hearing feedback and making changes for future events. And then finally, so on the table when you came in were copies of the data books. There are some more copies out at the registration desk if you need another 1 or 2 copies. If you are interested and have a use for more than a couple copies, we would be happy to ship those to you. They are free. We will also cover the shipping costs. So if you need multiple, please contact us, and we will get those to you for use within your agency or however you would see the best use for those. So thank you again for coming, and Shannon, I will pass it to you.
Okay, so thank you, Ryan. Thank you to everybody that participated on the panel and Dr. Weaver for facilitating the panel today. And thank you all for your wonderful comments and great questions. I know after we got done speaking this morning, I had quite a few folks come up to me and say, well, this is what's going on in my organization. You know, what do you think we can do together? And so I was very inspired by that, and my response was, let's stay in touch. When I'm in St. Louis, when I'm in Kansas City or down south, or when you're in Columbia, let's have lunch. Let's start the conversation. Because as I mentioned before, we are facing tight times, and we have to leverage all of our resources in this room. So thank you all for sharing with me and reaching out during that lunch break. I hope you all were able to make valuable connections across the board. It's all right. I just wanted to point out that we have, actually, it's fine that it's not coming up. There's always going to be a technical glitch. Oh, hey. I wanted to point out a couple resources that are on your table. These are different ways that we can connect in the future as a community. And this is the task of MOHEC. Like I said before, it's to connect everybody. So the first thing I want to talk about is we have already scheduled out our regional meetings. I'm so proud of us for the next 2 years. So over the next 2 falls, we're going to be in 4 separate locations throughout the state of Missouri. And we are always happy to help collaborate and think about traveling to other meetings, of course, outside of these regional meetings. But this fall, we're going to be in Columbia and in St. Louis. And it looks like we don't have the date for, September in Columbia and November in St. Louis. And so this is an opportunity, it's sort of open right now. It's an opportunity if any one of you want to talk about your data projects or your research projects or your initiatives, your programs going on in the community, or if there's a special topic that we just need to sit around and have a panel discussion about how to get some work done, this is the place to do it. So I want to invite all of you to think about connecting with me on that for these upcoming events in this fall. And then next fall, we're going to be visiting Springfield and Sikeston. And this is our second round of regional meetings, and we had some really great discussions over the last couple years when we had these regional meetings. So we've already had discussions in Columbia where we heard about healthy community initiatives going on in Sedalia and here in Columbia. We talked with Dr. Ross in St. Louis about health disparities. We talked with Cynthia Dean already once when we were down in the Boot Heel. We talked about the homeless issues going on and the great work being done out of the kitchen in Springfield. And so we are, and a lot of people did walk away going, hey, I didn't know about that organization, or I didn't realize that I could reach out in this way. So let's all continue the discussion at the regional meetings. A date that's not on here is also our 2014 conference coming up for MOHEC. That will be April 25th, I believe. It will be hosted here in Columbia, right here in the Hampton Inn, as a matter of fact. So again, this is another opportunity for us to have breakout discussions about some hard issues, figure out some next steps, how we can continue to work together. The last thing I want to do is point out our website, and really this other flyer points to some really specific resources that we have that hopefully you all can use. There's on many of these tabs through our research, our recent resources and Missouri Research, we have all of those regional meeting discussions. All the PowerPoint presentations are linked on there. So if you want to gain a better understanding of what people are doing throughout the state, you can look at some of our past presentations. And our last conference is also posted on there, and there are live feeds from Dr. Levine's speech and things like that. So we have some nice resources in that way. Also, there's a list of collaborators. I hope that every one of you goes back and clicks on that link to see if you're on there, and if you're not, that you register or tell me, put our name on there. That list is also connected to our listserv, and I mentioned that earlier today. Not only can we push information out, but we encourage you all to push information back so that we can circulate those conversations amongst everybody here. Also, you have access to neat snippets from different key resources, and I would like to replace, I really love Unnatural Causes. It's an incredible film that really does highlight very specific challenges that really connect us to what are the social determinants of health and things like that. But I'd like to have Ms. Dean's video about the fatherhood program. I'd like to highlight some things like that on this website. So if you have things like that to highlight, please do contact me. So with that, again, thank you to everybody here for participating today, and to the Missouri Foundation for Health for their continued support. And if there are no questions, I think that we can close.
I forgot one thing. I promised Domingo that I would talk about next week. There is a conference at University of Missouri St. Louis. The Cambio de Colores conference runs Wednesday through Friday. It is in the Millennium Student Center at UMSL, University of Missouri St. Louis. The website for the conference is cambiodecolores.org. So, and Domingo is here. There he is. So if you have any questions, please see him. Thank you all for coming. Safe travel.
Thank you.